Hello, everyone. Good morning and good afternoon to everyone and each one of you joining us today from all corners of the world. It is a pleasure to have you with us and happy Wealth and Bosses Day. I am Eleftheria and I am from Cardinal Health Medical Affairs. We are joined by two esteemed experts, Dr. Cohen from Guy's and St. Thomas's in London and Professor Rupert Bauersachs from the Cardiologic Center CCB in Frankfurt. Today, we have the pleasure to discuss with these two experts and all of you the details behind VTE epidemiology, risk assessments, patient needs and challenges, as well as present and analyze clinical cases and how to apply state-of-the-art practices. I would like to ask all of you to use the Q&A function throughout the sessions at the bottom of your screens, where you will be able to submit questions and ask us anything or comment on anything or give us feedback. We will address all of your comments, feedback, and questions in the end. During the event, we will also have some poll questions, and we would kindly ask you to submit your answers. Now, without any further delay, I have the pleasure to welcome our first speaker, Dr. Cohen. I'd like to ask you to share your slides and start your presentation.
Thank you very much, Eleftheria. It's a great pleasure and honor to be involved in this World Thrombosis Day project, particularly with my friend and esteemed colleague, Professor Rupert Bauersachs. And I always enjoy my interactions with him. And my topic to start the process is venous thromboembolism, epidemiology, and risk assessment. And this is where I work at St. Thomas's Hospital on Westminster Bridge, but we also have another hospital, Guy's Hospital, which is up on London Bridge. And I'm grateful to my colleagues who are covering me. This is a disclaimer stating the relationship between what is being presented and the sponsoring company, Cardinal Health, and the presentation is being developed for educational purposes. These are my disclosures for research support, consultancy and honoraria, Speakers Bureau and Scientific Advisory Board. And I ask you to keep that in mind as I'm presenting the data. So this is a patient of mine that was entered into one of the studies, the randomized trials for DOACs. A patient with multiple PE, bilateral PE. You can see some right ventricular enlargement compared to the left ventricle in the transvalvular measurements. And this is a patient that did very well on DOACs. This is a patient also with pulmonary embolus, but here we have a large saddle embolus associated with hypotension. And this patient required thrombolysis and clot removal prior to starting anticoagulants. The key to understanding risk assessment and stopping this occurring is having a degree of suspicion. And having a degree of suspicion about whether a patient may have a pulmonary embolus or a deep vein thrombosis. And if I may, I'll ask for the first question related to this particular subject. And we really want to concentrate just at first on fatal pulmonary embolism. And the question relates to how often is fatal pulmonary embolism suspected prior to death? So how often do people think this patient might have a pulmonary embolus prior to dying from a pulmonary embolus? And is the answer the majority of patients, half the patients, or less than half the patients? And I'd like you to guess or make your estimate now, please. You know, we often think as clinicians, we know what's going on and we understand what the problem is prior to death. But this is probably not the case with pulmonary embolism. So thank you very much for voting. About half said less than half the patients, about a third said half the patients, and about a quarter said the majority of patients. And that's very interesting because I think it might have changed over the years, and but what we do know is that when we look at the cause of death, and I'll move on to my next slide, in these studies performed by esteemed thrombosis experts, if we look in the right-hand column, these were patients who died from pulmonary embolism. They had pulmonary embolism, a major pulmonary embolism, many of which had autopsies, and it was suspected in less than half the patients. And this was up to, the turn of the last century. But I don't think things have changed too much, because we still see people dying from fatal pulmonary embolism being managed for heart failure, infectious disease, asthma, syncope, lots of things. We don't suspect pulmonary embolism. And it's a problem, because if we don't suspect it, when those patients come to outpatients or come to casualty, they may not leave by walking out of the hospital. And if we don't recognize and treat pulmonary embolism, then people will die from pulmonary embolism quite often. And we've seen from the placebo arm or the controlled arm of the Barrett and Jordan study that a quarter of the patients died and a quarter of the patients had recurrences. So it's a serious problem for over half the patients that develop a PE, and the other half may have ongoing problems too. It's also a major problem throughout the world. And we, almost 2 decades ago, undertook some epidemiology, which we published in 2005 and 2007. And we looked at Europe and United States, and we saw there were a significant number of deaths related to pulmonary embolism. And remember that United States and Europe represents a fraction of the world's population, less than 10%. And that 57% of the world's population is in Asia, now 58% now. And we think conservatively, there are over 3 million deaths every year from pulmonary embolism, many of which aren't detected. And back in 2007, we made this claim when HIV/AIDS was a real concern for everyone. And so are many cancers, and they still are, and transport, that the deaths in Europe from pulmonary embolism and venous thromboembolism far outweighed the deaths when you combine those deaths from transport, accidents, prostate cancer, breast cancer, and AIDS. And that's a claim we made over 15 years ago. The other thing of interest is that the mortality, the 30-day mortality, is highest in elderly populations, and it's mainly in PE patients. So we can see that the 30-day mortality is also present for DVT patients. They may be dying of comorbidities, but the PE patients have the highest risk in the green, and these are the patients that have the worst risk with age. And we have an aging population in most first world countries, but also in other countries throughout the world, the populations are aging. There are other problems which we could just talk about on their own, like post-thrombotic syndrome. And post-thrombotic syndrome is not only something that is a cosmetic problem, it's a major problem on quality of life, and very, very expensive when we manage venous ulceration of the lower limbs. And of course, the most feared complication apart from death from PE is chronic thromboembolic pulmonary hypertension that occurs in 3 to 4% of patients that have had a pulmonary embolism. And it's difficult to manage and may need surgery, expensive and debilitating surgery like this patient had. It's not just a problem for the elderly. And I might just, before I show you that slide, ask you the next question. which patients have the highest risk of recurrences? Is it the elderly? Is it the young? Or is it both the elderly and the young? We know, you can vote now if you wish. I'll just talk while you're voting. We know that some risk scores, like the DASH score, think that age less than 50 is important for recurrences. And other risk scores, like the HER2 score, think that advanced age is an important risk factor. So who's right? Is it the elderly? Is it the young, or both? And fortunately, 2/3 of you know that it's both the elderly and the young. And that's absolutely correct. And if we look at the epidemiological data, which is on the next slide, this is a piece of work we published 8 years ago. And we're able to get good incidence figures for recurrences because we had over 26 million patient years of follow-up. And what you can see here is that these are the incidence for recurrences for men and women. And DVT particularly recur very frequently in young people. And that's because they've got healthy vessels. And if they've got healthy vessels, they must have something very prothrombotic to develop a thrombosis in the first place. So stop the treatment in a young person, and there's a high chance of recurring. The other people, as you can see on the right-hand side of this graph, that have high recurrence rates are the elderly patients. You see from about the age of 40 or 50, there's a steady increase in recurrence rates. And that's because elderly patients have comorbidities, they have damaged vessels, they are relatively immobile, and they have a higher risk of recurrence too. They've almost earned it because of all the problems that they've had over the years. So both young and old are at risk. We know that we need to continue anticoagulation for some patients, such as those with unprovoked VTE, or such as those with recurrences, or perhaps patients with active cancer. We also know that some patients we can only need to treat for 3 months. And this work by Trevor Baglan shows the recurrence rates of patients, whether they're provoked by major surgery, where there were no recurrences in his study, or whether they were unprovoked, where there was over a 2-year period, 17% recurrences. The ones that are challenging us are not those. The ones that are challenging us now are the ones in the middle, the ones with obesity, the ones with chronic renal impairment, the ones with minor risk factors that led to the initial thrombosis, a bit of trauma, a bit of travel, a little bit of estrogen. They're the ones we're concerned about having long-term problems and have to make that decision on the risk and benefit of either stopping or continuing anticoagulation. And the question that's important is the risk benefit. And in the first 3 months, the risk benefit's pretty much the same, whether you have a thrombosis or you have a bleed. The case fatality rate is very similar in the first 3 months. But after 3 months, the case fatality rate for major bleeding is higher than the case fatality rate for recurrences. And so when we're thinking about continuing, this is just one study, but there are several studies that have shown this. When we think about continuing anticoagulation, we want the incidence of bleeding, major bleeding, to be about 1/3 of the incidence of recurrences. So 6% for recurrences, 2% for major bleeding. Then we might say there's equipoise in continuing stopping treatment. But there's lots of things to take into account, patient preference and so on. So we need to individualize the treatment. And this work, which I won't go into, from the European Society of Cardiology, I think is very helpful, where they work out the low risk of recurrence, who we stop, the intermediate risk, as I've just discussed, and the high risk that we continue. Of course, cancer is increasing because we're living longer, and cancer is also more and more associated with venous thrombosis. And I want to ask yet another question now about cancer, and this is my last question for the people online, about the cancers with the highest incidence of VTE, cancers like stomach cancer or brain cancer or pancreatic cancer. Do those cancers with a high incidence of VTE result in the highest burdens or prevalence of VTE? It's just a true or false question, and you can answer now. So are most of the cancer-associated thrombosis you see in your clinic, are they related to the high incidence tumors like pancreas, brain, stomach, or are they other cancers that have the highest prevalence? And we'll just have a look at your answers now. Well, it's an interesting spread. About 3/4 said they are the highest burden, and 1/4 says it's false. So I'll come back to that. I'll close that question now, and we'll move on. This is a patient from a colleague of mine, Anthony Maraveas, who has cancer, and you can see pulmonary emboli. Let's have a look at the risk factors. Chi and I from Vienna, a colleague of mine, I worked with him on producing this table, and we know the risks. We know they're patient-related or tumor-related or treatment-related or biomarkers. But when I'm sitting in front of a patient with cancer-related thrombosis, I'm really thinking about just the tumor-related and the treatment-related, as well as the others, but they're the main ones, the driving force. Is it a high-risk tumor? Is it a metastatic tumor? How recently was the diagnosis made? And then what's their treatment? Are they getting chemotherapy, platinum chemotherapy, if they had surgery, hormonal therapy, and so on? Of course, their medical, their patient-related risk factors and biomarkers are important, but they don't drive me as much into making decisions. So this is cancer incidence from Fritz Mulder's paper from last year. And what it shows is that the incidence of venous thrombosis in a cancer cohort has increased greatly over the last 20 years. And when we look further at that, the main increase is in patients with PE. There's some increase in DVT, but PE is driving this. And this may be for a number of reasons, including greater suspicion, including staging CTs, and people being much more aware of the condition. There are lots of consequences of cancer-associated thrombosis. We know they bleed more, they recur more, they cost more, they have higher morbidity and mortality, they have more visits to hospital, it interrupts their therapy, worse quality of life. So it's something we need to work out how to prevent, and I'm sure Rupert and I will discuss this very shortly. But this comes back to the first question I put to you. And this is a study of 6,500 patients with cancer-associated thrombosis. And who had the highest prevalence? Well, actually, the highest prevalence was in men with prostate cancer, followed by women with breast cancer, and both men and women with lung and colon cancer. And actually, the high-risk cancers like pancreas, brain and stomach contributed less than 10% to the overall burden. And that's because although the incidence is very high, these patients die, these patients don't get followed as long, whereas the more common chronic type of cancers, the ones that people live with, contribute more in time and are more likely to go on and develop a cancer-associated thrombosis, particularly as the disease progresses when they get older. So some areas we need to think about. We've been talking about traveling in cramped conditions for a long time. And this Joey from my home country obviously has cramped conditions, but not too troubled with venous thrombosis, I think. This patient's a different story altogether. Although they have plenty of room, they're suffering from a number of factors: immobility and obesity. And I would like to point out that about 60% of people over 60 in this country are overweight, and about 30% are obese with their BMIs greater than 30. So this is an epidemic we need to deal with, and we need to work out what to do. In fact, the term SITS, I think, is quite interesting because it's about sitting around or lying around, and it's the seated immobility venous thromboembolism syndrome, which was coined by Beasley, but it's been looked at by a number of people, including my colleague, Dr. Chowser, who looked at lockdown thrombosis. And we've seen thrombosis associated with everything from bomb shelters to being locked down with COVID-19. It's something we need to get better at sorting out, and that's going to be a major challenge. It's a big challenge in England, and particularly London, if it affects the London cab driver. And this is just an article about someone who took a long trip in a taxi and died. It's also previously, and this is obviously an old photo because most of this equipment looks out of date, but it's e-thrombosis, with office-related thrombosis, other media perceptions, and some people just take this a bit too far and have their desktop on top of their grave. So it's something that is a challenge for all of us. The other challenge is obesity, and obesity is a challenge because it's a risk factor for so many things: venous thrombosis recurrence, cancer, hypertension, diabetes. But actually, if we look at who develops post-thrombotic syndrome, it's summed up by this slide. Post-thrombotic syndrome, more common in women, more common with age, and more common with obesity. And they're three independent risk factors. So obesity is going to be a huge challenge for us as thrombosis doctors, but also as doctors practicing public health. There are a lot of risk factors, and that's the beauty of this subject. If you're involved in this subject, there's not a single organ that doesn't have an artery and a vein. And if there's a vein, there's going to be a thrombosis in some situations. And it affects all range of patients, all types of diseases, acute and chronic, and surgery. So it's a lovely subject to get involved in because it's so broad. And it's also a lovely subject because you can choose an area and try and hone down on your research. We know that the risk goes on, but we don't know when the risk balance changes. So this is a lovely study by Sean Sweetman, and I think it came out of Valerie Burrell's department in Oxford. Valerie died recently. She was a wonderful epidemiologist. And this looked at, in the Million Women study, the risk of thrombosis after surgery. And what we kind of knew already, that the risk is highest in the first 6 weeks, but still there many weeks later, peaks at 3 weeks. The hip surgery, cancer, knee surgery, fractures were the highest risk. But this is the interesting thing, whether it's major inpatient surgery or day case surgery, the risk continues. And we haven't got to the bottom of extended prophylaxis and who to give the treatment to. So there's another challenge for us. We need good risk assessment models. And yesterday I presented why we needed a RAM, something we published almost 20 years ago. But the key thing is that it keeps it in our minds, that we're thinking, is this patient at risk of venous thromboembolism? There's lots of RAMs, and this is one of the first RAMs that we developed, but it's complex and it requires looking at evidence-based and consensus-based. And I think we need to do that when we develop a RAM. We need to clearly say, this is based on evidence, or this is based on consensus, and how that evidence was derived so that we can work out what to do. Some patients don't need thromboprophylaxis, and that's good. And others may not be suitable for pharmacological prophylaxis. I kind of like these opt-out RAMs where you say, well, all patients at risk, if there's no contraindication, give thromboprophylaxis. It doesn't discriminate between high risk and low risk, but if you've got risk factors, you are at risk. It's just a matter of the risk of better. And this is the more modern view on RAMs, not very different from what we came up with 20 years ago. I think that we have better ways of assessing the risk assessment models, and we have better tools for looking at bias. And this is one tool that looked at bias. And I think that this was a very interesting study by Pandor and colleagues with my colleague, Professor Beverly Hunt from St. Thomas's Hospital and Guy's. And what they showed was that when we look at the risk of bias in over 20 risk assessment tools for thrombosis, all of them had a high risk of bias. This red bar at the top had a high risk of bias. And the rest, it was unclear because there was insufficient evidence to determine whether there was bias or not. So we've really got to do a bit better. Why is there bias? Well, if we look at the 3 or 4 main risk assessment models, the proportion of study population who received thromboprophylaxis, 44% for IMPROVE, 16% for Padua, 57% for Geneva, 61% for Cabrini. That's either in the derivation or the validation model. The point here is that if people are getting thromboprophylaxis, the high-risk patients will look relatively low, and the low-risk patients will start to look like high-risk patients because they're not getting thromboprophylaxis. So that introduces enormous biases into risk assessment. We need a clean population, either historical, randomized controlled trial, or a future population that is not getting regular prophylaxis. Too little, too late. Well, it was too little, too late for this hearse driver, but it's not too little, too late for us. We've done a lot and we've come a long way. We've got to go even further. And I'm going to stop now and thank you for your attention and hand over to my colleague, Professor Rupert Bauersachs. Thank you.
Thank you very much, and I really appreciate everyone is finding the conversation quite stimulating and informative. I'd like to ask the audience to continue to submit your questions in the Q&A function because we will incorporate everything in our discussion in the end. But before we do so, let's welcome our second speaker, Professor Bauersachs. Can you please share your screen and start your presentation, and all of your questions will be addressed in the end. Thank you.
Yes, thank you very much. And it's now about applying the state-of-the-art practice, as we've just heard, to your patient. Here are my disclosures. I would like to start with Anne. She's an elderly lady. She's frail, as you can see here, and she got dizzy during her household work and fell, and she suffered a hip fracture from that. And you can see her comorbidities: type 2 diabetes, hypertension, arthritis. Because of the arthritis, she's on steroids for a long time already, and she frequently needs NSAIDs. And she had already a PE 10 years ago. While she was immobilized, she also received steroids at that time with the disc prolapse. If you look at her blood values here, you can see that she's anemic, and you can see that the renal function is somewhat impaired. And of course, now a total hip replacement is planned. And now we have to, as we just heard from Ander, have to consider thromboprophylaxis. What kind of thromboprophylaxis would be performed in that lady? And of course, the colleagues, discussed that and decided to give her enoxaparin 20 milligram once daily. So we don't, just as in real life, we don't really know the end of the story. And you may think and by yourself, what is that? Do you think that is enough, or is it too much already? Because she has obviously a high bleeding risk here, and she's anemic already. So is it too much? Is it too little? Remember that she has impaired renal function. So we don't know in advance. It's a challenging situation because her thromboembolic risk is also high, because during this comparable situation, she had suffered a PE already. Well, anyway, she received 20 milligram enoxaparin, and actually the surgery went well. She recovered quite well, but after an initial improvement, she complained about increasing leg pain and the swelling, and also difficulty breathing. Well, you can imagine already what happened. She had a thrombosis and a suspected PE. And now the question is really, she was, of course, fully anticoagulated with a low molecular weight heparin at that time for the first 4 weeks. And she, not unexpectedly, found to have a positive test for alcohol blood in her stool, and the gastroscopy showed severe erosive gastritis. She was put on PPIs, and after 4 weeks, she was finally switched to apixaban. So let's discuss that case. She did receive pharmacologic thromboprophylaxis, and yet she suffered from post-op VTE. And now, post-hoc, now we have to decide, have we really done enough? Or could we have done more to prevent a potentially fatal VTE in that elderly lady? And clearly, we have to holistically assess that patient. She had a very high risk of VTE. She already in the past had PE. She had undergo surgery with a very high risk for VTE anyway. Hip replacement is one of the highest risk for PE and DVT. But we recognize that at the same time, this frail elderly lady has a very high risk for bleeding. And of course, we're afraid to use, if we use pharmacologic thromboprophylaxis, that we do not have accumulation of low molecular weight heparin in that patient with impaired renal function. And she already had gastric lesions. I mean, that I think was suspected from the history already. So it's, I think, important to look at the whole patient and choose the right combination and administration of pharmacological prophylaxis, but also we have to think about mechanical prophylaxis, which is especially important in patients with a high bleeding risk. And that old lady, of course, was a perfect example for that. So that's one case that we can discuss afterwards. And I would really like to move on to another case, applying the state-of-the-art of practice to that patient. And it's a completely different patient. It's a man now, it's a young man. And you can see the risk factor for his injury was also completely different. Yet a really dangerous situation. This young guy had main injuries in the head, in the face, in the right shoulder and arm, Glasgow Coma Scale 3. So he required mechanical ventilation, had subdural hematoma, had epidural hematoma, fractures of the petrous bone, skull base, cerebral edema. And over the course of the next hours, he really developed subsequent intracranial pressure increase. So you can see the edema of the brain, and he had to undergo bifrontal craniectomy. Now we're kind of in the same situation that we had before, and thinking about what do we do in that young chap about thromboprophylaxis. And of course, this patient has a very high risk for VTE. And of course, this patient has a very high risk for bleeding. The ICU doctors were quite brave, and they put him on unfractionated heparin perfusion, 700 units per hour, which is actually quite brave, I think. And you don't know the outcome. So what do you think would happen? I mean, in that patient, would you, with that kind of thromboprophylaxis, expect a PE or a DVT, or would you expect an increase of the cerebral bleed. It's a very, very difficult situation with a very high bleeding risk and a very high PE risk. And as in real life, we don't know the outcome yet. Let's look at the further course of the patient. 4 days later, he developed high temperature, fever, white blood cell count went up to 25,000, C-reactive protein greatly elevated. The VAR showed, of course, different germs, and blood cultures at that time were negative. But this guy was really in sepsis or approaching sepsis, had a severe infection, which again, of course, increases the risk for VTE. And in fact, 1 day later, this patient went into acute cardiovascular shock, tachycardiac with 150 per minute heart rate, and he was hypertensive. And you can see the emergency echo here. You see the right ventricle greatly dilated, and the left ventricle is almost empty, and acute, very high pulmonary hypertension with 50 millimeters of mercury. So this patient had acute PE with acute shock, requiring vasopressors and catecholamines. And again, the fact that this patient now suffered a PE makes the difficult situation even more dangerous. And because now it was decided to react quickly, and that the decision was that he underwent fibrinolysis with a reduced dose. And of course, you expect what happens after fibrinolysis. You see an increase of the hemorrhage, midline shift, intracranial pressure, increased in addition, so immediate puncture, neurosurgery, drainage. Very, very dangerous situation. Fortunately, this young man really was fortunate. He was discharged from the hospital after quite some time with normal cardiac function, moderate neurological impairment. He was able to walk without assistance and was slowly going back to his old job. And it kind of illustrates, if we look at the discussion of that case, that it's a trauma patient, severe head injury requiring mechanical ventilation. So that's a high risk for bleeding, of course. ICU, mechanical ventilation, that's a high risk for VTE. So again, we have to look at the whole patient and do the assessment. And remember, that patient received unfractionated heparin in a substantial dose for prophylaxis for his high risk of VTE, while at the same time, the patient has a high risk for bleeding. And again, we have to consider the right combination of administration of a pharmacological and mechanical methods to prevent VTE, which, as you can see in that case, really deteriorates the situation and may be, fatal. So that patient was lucky, but I think what we can conclude is that we really have to have a comprehensive and systematic evidence-based approach in these patients. We have to look holistically at the patient. It's important to have multidisciplinaries working together for a successful implementation of a RAM, as we've just seen it from Ander. Continuous monitoring, because the patients are changing, their risk is changing, of the process and the outcomes to improve patient care. And in conclusion, it's all about the patient. And it's also important to involve the patient and their condition at every stage. Thank you very much.
Thank you very much to both of our speakers. We have been seeing questions come through. So everyone has found it very informative, very useful, and with a variation also of topics. I mean, Ander touched a little bit on cancers, and a lot of us are wondering how should we be assessing VTE risk in cancer patients with maybe other comorbidities in the mix. But Rupert has gave us some insight on patients young and old with the different fractures or not, different histories, and how do we move forward to have the most desirable effect for patient safety. So saying that, we actually have a question that's a bit double-armed. So imagine you have an elderly lady or gentleman and has gone in for hip replacement with a known condition to be classed as high risk. Now, the question is, do you recommend a perioperative prophylaxis against VTE, and what would that prophylaxis be? And also, if the patient is still not mobile but is being discharged, how would you follow on offering mechanical prophylaxis when they actually go home? So who wants to start? I'm happy. Rupert, do you want to take us first?
I can answer that, and it's interesting because Anna mentioned the opt-out RAM, and that's something that is really applied a bit in Germany, so that everybody receives thromboprophylaxis. But these patients also have a high risk after their hip replacement, for example, knee replacement. They may develop hematoma or oozing, and then leading to infection. So one has to be careful not to overdo that, and there's always a bleeding and infection risk. And what we do now in the hospital, and they are discharged really quickly with the mechanical intermittent compression devices. You can also do this on an outpatient scale. So that works, and it's done by the nurses usually and assistant personnel, and they show it to the patient. That's possible to do it on an outpatient. And the advantage really is that you don't have an increased risk of bleeding, because that's what happens if you, in these elderly patients with impaired renal function, you get comminution of low molecular weight heparins, and then you get hematoma, and you may get infection. So it's possible. You have to structure it, but I think it's logistically very easy once it's established.
And I know you have a bit of a controversial opinion when it comes to perioperative mechanical prophylaxis, but what would you recommend if someone has contraindications to pharma and they need to be discharged and they're not mobile?
Very difficult, because the more effective mechanical methods may have an important role, and yet they require quite a bit of equipment. And I think that these cases that Rupert raised makes me think about more of a sort of hybrid approach. What you do early and what you do late. So I think that if a patient has had major surgery and they need thromboprophylaxis, then, and it's got to be mechanical, then it's difficult to discharge them early. But you could encourage mobility. You could perhaps use a lower dose of anticoagulation than what is normally recommended. So take Rupert's patient, for instance, that had the 20 milligrams of enoxaparin. Now, for hip surgery, we generally recommend 40, even when someone's got a creatinine clearance above 20, which this patient had, even if they're frail. But instead of them having a thrombosis, they may have had a major bleed. So the balance there. The other patient received intravenous heparin, and at quite a decent dose, per something equivalent to what might be considered as sort of high intensity thromboprophylaxis. But we know unfractionated heparin has a higher bleeding rate than low molecular weight heparin. And yet it's much easier to, one would think, if we titrate the dose and can actually give it at a rate per hour, there's going to be less peaks and troughs. So very the difficult situations. But I think that we haven't got good evidence for mechanical prophylaxis as a rule. And it might be, it might be beneficial. It doesn't seem to be in any of the big studies, particularly stockings. And so therefore, if we've got to send someone home, it's either going to be a complicated machine going home with them, or you're going to have to say, you're not as well protected as you should be, and you need to be absolutely vigilant for any leg swelling, chest pain, shortness of breath, or cough, or any change in neurological symptoms too, because we know that PE can present with dizziness and syncope a lot more than we thought it was. So tough question, Eleftheria, but I'm not sure I'd feel happy reassuring a patient that they're either wearing stockings or taking mechanical prophylaxis at home.
And I think the patients that you mentioned or that I showed, they are typical examples where the physician in charge is in doubt, and they are in doubt. They would select a too low dose of heparin or a rather high dose in the second case. And I think if these situations arise, I think that's a strong argument for me to use combined thromboprophylaxis methods.
Yeah.
And so that's really a key. Once you are unsure and you have a high bleeding risk, you have a high risk for VTE. That's shouting for a combined methodology. We do that, and that's beyond our topic today, thromboprophylaxis, but we also use that on and including outpatients after major vascular surgery, where patients have a strong edema and they need, of course, thromboprophylaxis also. And I can tell you that once it's established, the logistics of these machines, they are very small, are very simple, and it's a great benefit, and it's very easy to perform. And Eleftheria, you just mentioned the cancer patients.
Yeah.
And we really have the same problem there. They have a very high risk of recurrence, and I showed the risk factors, and many patients have multiple risk factors. And at the same time, they have a high bleeding risk. And it's not only that if they suffer a bleeding while they are on anticoagulant strategies, that the bleeding risk, and that's dangerous, but also it interrupts their anti-cancer treatment. So that makes things very complicated. And again, whenever there is, and often they are thrombopenic or they have bleeding from their cancer, which is still in situ and so on. I think that is for me an indication, well, let's just do as much as we can and look at and think about combined modalities.
And always be prepared for any consequences, because of course this could be the patients that keep coming back to our care. So we would need to reevaluate the protocols.
Yeah, I think when they do come back, Eleftheria, when I talked about a hybrid method, just keep, and we're always told to do this, just keep reassessing the risk. Has the bleeding risk diminished because that elderly patient is now on a PPI and maybe has had the gastritis or whatever puts them at risk treated? Therefore, I can go a bit harder on the, pharmacological prophylaxis, or have they, had to have some other drug added in, like an antiplatelet therapy, and therefore I want to back off on the anticoagulant. I wanted to ask Rupert if I could. He raised a very good point about, after other forms of surgery, particularly vascular surgery, some of it's open, some of it's not. How much use of the Voyager type treatment or the Compass treatment? How much are you using a combination of, say, the lower dose of, say,
for the first time, we really have a large randomized controlled trial that shows a benefit and not only a bleeding risk, as we just had, with the other trials like the BOA trial or CASPA trial, they were negative and just increased the bleeding risk. And especially the surgical patients, the vascular surgical patients, they had a big benefit. And again, it's very, very similar to what we're talking. There had been all kinds of modalities that have been used with full anticoagulation or double platelet inhibition by the surgeons, because they are afraid that their bypass, gets thrombosed or occluded. But now we have an evidence-based regimen, and the vascular surgeons really are taking on that regimen quite openly.
And could I ask you, what are your thoughts on the future of factor 11 A inhibitors or factor 11 inhibitors, either A or not A, but factor 11 inhibitors in prophylaxis?
I think the fact that this development of factor 11 inhibitors is really taking off shows that we are still not happy with the pharmacological measures that we have today. So the vision that we have with factor 11 inhibitors is it is an anticoagulation with no bleeding risk. And that's why everybody jumps on that topic. So we are still not happy with what we have. And one interesting aspect of the factor 11 would be also, as you know, some of the antisense oligonucleotides, for example, or the antibodies have a very long half-life. And so that would enable you to have a prolonged protection. But I think we have to see whether the promise of good anticoagulant effect with no bleeding risk really holds true. And for me, it just shows we need to get better than we are today. And of course, we were excited to see the study results. And at present, the studies are not big enough, I think.
Yeah, and there was an interesting question there I saw on sort of hypothermia and the intermittent pneumatic compression. I mean, one of the things with whenever you have people with compromised peripheral circulation, and that can occur in hypothermia, you get a shutdown peripherally. It can occur in peripheral vascular disease. It can occur in shock. You know, the use of mechanical methods is probably not the ones to use. I mean, you need to think about something that is going to not affect the circulation to the limbs more than that. Would you agree, Rupert?
I think it's always useful to look at whether there are pulses. That's the easiest thing. It's useful not only for that purpose, but for many other reasons. I think that's something that needs to be done. And it's our task also to teach that, because it's not that easy when you're not trained.
Finally, Nafru, but we also have a question. We have attendees from Germany, and they're wondering, what is your point of view of why they don't see intermittent pneumatic compression being more widespread used within Germany?
Yeah, I can tell you, and especially since we are using that quite frequently, it's also a matter of health insurance. So we have different public health insurer who are paying the cost and reimbursing it, and others don't. And so there's variation, which is unfair to the patient, but that's the situation at present. But I think what I observed over the last couple of years, that it is really changing, and there's a shift, because in the end, it leads to a shorter hospital stay. And that's the reason why some of the health insurers are changing now. But I think that's one of the biggest obstacles in Germany.
And what do you think we can do to, help maybe change the practices? Is it down to more education maybe, or providing more local data, maybe?
I think it's
geographic data within Germany for the benefits.
I think, again, it's a multifactorial approach. I think it's the data and the evidence, and that's the point that Ander mentioned. But it's also there's a burden of an obstacle to use a new methodology, which sounds complicated, but it's not once you've seen it. So I think that's also with some peer contact, or like hospitals, like looking at other centers who use that on a routine base, and you see it's very easy. So that would be from the practical side. Evidence side is important. Reimbursement side. So these are different sides that have to be tackled, and so it's not just one thing.
We do have a question on obesity and the sitting disease. Sometimes these people actually are being classed in the intermediate category, and the audience is wondering whether we should be classing them at the highest risk category when assessing them.
Yeah, I think that's a fascinating question, because it depends whether you want to treat intermediate or you want to get them into the high risk to treat them long term or prevent. And, I think obesity is a long-term risk factor, and immobility is for people who have problems with movement. I have patients in wheelchairs that are at risk of clots. I always go back to some of the epidemiology that looked at elderly patients in nursing homes. And what the old epidemiology said was that, if you're an elderly person in a nursing home sitting around, you're not at risk of thrombosis any more than any other elderly person. But if you're an elderly person in a nursing home that gets ill, then your risk goes straight up. So, infectious diseases, pneumonia, urinary tract, skin infections, a heart failure, respiratory failure, up goes the risk. So I think it's the combination. I think we've got to think in like immobile and obese, immobile and a history of VTE, immobile and inflammatory disease. So these are things that just, these aren't always yes or no. They're what we think of in terms of thresholds. Immobility takes you up. One more thing gets you over the threshold. So that's how I think, but I don't know whether that's right. It's just the way I work.
What do you think, Rupert?
Well, it's Virchow, it's really, it's World Thrombosis Day, it's Virchow's birthday, and it's always three things coming together. Just as Anna said, it's one thing which is not, it's just nursing home is nothing. But then there's the immobility or the obesity or the hormones. So it's very often, it's really more than two, it's three things coming together, and then you get the established DVT or PE.
So lately, we have been coming across quite a controversial issue. We have always been saying, keep as active as possible, go the extra mile, literally, trying to do the best you can. So when something happens, you have the best head start, let's say. However, we have been sharing some patient experience where people have been of an athlete's sort of caliber, or they have been into amateur races, training every day, and they still found themselves to develop a clot, unfortunately, when they needed major operation. So people are turning around and sort of thinking, if I'm going to have the same risks exercising all the time or just sitting and, as Anders showed, playing PlayStation, I'm the same era, I don't know what the latest platform is. What would be our advice going out there and continuing to try and convince them to keep active?
Well, my advice is that one swallow doesn't make a summer. And, the fact that an athlete, I see Olympic athletes that get thrombosis. Serena Williams got a thrombosis. Flintoff, the cricketer, got a thrombosis. Look, it protects you, we think, from vascular disease. It won't protect everyone if you've got some, thrombophilia or some reason. So don't be put off by one or two cases. The overall message is healthy lifestyle, less disease, most diseases. So keep going with your exercise.
So we're coming up to time, and I'd like, to thank everyone. I'd like to conclude, some of the messages we spoke about today, discussed. Hopefully, we created some healthy conversation to the people that are watching us from around the world. And, we have said, keep always in mind, perioperative care is the best. Correct the risk assessment, but as Anders said, reassess the patient and make sure that the assessment you gave at the beginning is the same, or maybe it has changed, and consider best practices when discharging the patient, keeping in mind that they could come back, they need to be reassessed, and you need to look at their follow-on VTE prophylaxis. But one thing I think came out of the conversation is timely and correct assessment of the patient for whatever prophylaxis you choose, whether this is multimodal, pharmacological or mechanical, is the secret. So by saying that, I want to deeply and sincerely thank everyone today, our esteemed speakers, both of you, invigorating conversation, great presentations, and our very diverse audience from around the globe who joined us today. And with that, Thank you, everyone. Happy Thrombosis Day and goodbye.